Alright, so this first video is going to be only on chapters 3 and 4, and then I'll make another video for the other chapters for the remaining. So there'll be 2 separate videos for this lecture, and it's just to help you not have to watch, a 30-minute video, because I know that you guys don't like those. You like them more about 15 minutes. So when I do videos, I try to keep them about that time frame if I can. So the first one we're going to talk about is chapter 3 in assessment. In this nursing process, assessment is your first phase, okay? This is where you're going to be collecting your data and gathering your information on your patient. And based off of all that information that you find, your assessment is going to basically determine the rest of the nursing process or your care plan. So if you hear the word nursing process and care plan, they're essentially one and the same. Assessment, what does it really mean when we say the word assessment? Well, it just means to gather your data. When you're talking to your patient or when you're talking to their family members, you're gathering data. When you're performing a physical assessment, when you're interpreting lab values, those are all different ways that we gather data, and there's a whole lot of other ways too that you'll learn throughout this semester. We need to collect all this data to provide good holistic care for our patient. So holistic, that's going to be a term that you're going to hear all throughout nursing school. And it's really a term that once you've graduated, that's the type of care that you need to provide to individuals. What holistic care is it's providing an individualized mental, spiritual, culture, and physical care. So we're not just concerned about the hip fracture that someone has. We're concerned with, what do they want to eat when they come in? Are they going to have the resources when they get out in the community in their home? Are they going to have the walker and stuff like that? If they are worried about childcare, what if it's a 30-year-old woman, single woman, and she has children at home? She's going to be worried about how is her children going to be taken care of. And so we need to be looking at every single aspect of that individual's perception whenever they're in the hospital. So the purpose of assessment is to obtain enough data to allow you to help your patients. How is your assessment data used? When you collect all this data, it's going to be used by the nursing staff to create a care plan and provide care. And it's also going to be used for referrals. So what does referrals mean? Let's say you have a diabetic patient who's came into the hospital with diabetic ketoacidosis, which just essentially means that they have high blood sugar. So based upon your assessment, your physical assessment, and maybe your interview of nutrition, you have determined this patient doesn't really understand how they need to eat when they're diabetic. Well, then you can refer them to a nutritionalist, a dietitian that can come in and speak to them. Or let's say you have a patient who is in the hospital and says that they can't afford their medications. Well, then we can refer them to social services and have them come in and talk about it. So all of our assessment data can be used in many different ways. Can you delegate your assessment? And the answer is no. You may not delegate your assessment. That's something that you need to do. And the Joint Commission has actually stated that an RN must complete the first initial assessment, and the LPNs will be able to complete further assessments. So what that means is you have a new patient come on to med-surg floor, and an RN must do the first initial assessment. Okay, so that's going to be the full history. An RN must do that. And then after the RN completes that assessment, she's gathered all this data, started creating care plans, then the LPN can come in and take care of that patient with no problem at all. But that is in the scope of the RN for that initial assessment. So there's different types of assessments that we can do. You can do an initial assessment, and then you have an ongoing assessment. And really ongoing is what you need to be doing on the hospital site. Okay, when you're in the hospitals, if you work in a hospital, you're going to be consistently collecting data every time you interact with that patient. And there's comprehensive. This is basically your initial interview assessment with your patient. Here you're going to gather all the information on. You're going to gather their religion. You're going to gather their holistic, everything holistically. Their allergies, their past surgeries, and all their information. And then there's going to be something that's called focused assessment. And that's more of like a walk-in clinic. Okay, you go in with a sore throat. Well, they're probably just going to look at the sore throat and not really be concerned with much else. Or if you're in an ER and they're going to fix the emergency problem first, they're going to focus on that emergency problem before they really go to anything else. So there's different sources of data that we have. There's subjective and objective data. Subjective data, just remember subjective as statements. Okay, this is what people, the patient or family members, are going to tell you. And then objective is information that has been gathered through physical assessment, lab, diagnostic data, those type of things. So objective is basically another nurse can come in and listen to the patient's breath sounds, and you guys can both determine, yeah, they're clear. The breath sounds are clear. So it's anything that's not a statement that another person can come in and get the same information. So review this box here. And oftentimes you need to use objective data to validate your subjective data. So remember, subjective is what the patient says. So let's say we have a patient that says that their pain is a 10 out of 10, okay? But your objective data tells you that they're laying in bed, they're not grimacing, they're not guarding anything, they're talking, they're joking, they don't appear to be in pain. Okay, so those two don't coincide with each other, and we'll talk a little bit more about that later. There's sources of data. Yeah, your primary data and your secondary data. Your primary data is going to be both the subjective and objective obtained from the client only. So that's going to be the data that you collected off of your physical assessment, your vital signs from that patient, and then anything the patient told you. Secondary data is secondhand data. That is information that you learned when you read their medical chart. That is information that you learned that other nurses told you, or that the family members told you. Okay? Observations. We kind of already talked about this a little bit. Every time you go into that room, you need to constantly be observing, making observations. You'll be less likely to miss an assessment area if you kind of do the same thing every time. And here's just a little called help that might help you to start doing this. And everyone does it a little bit different, but here's just a way to start organizing those thoughts. So the first one is help. This is when you walk into the room, always look at the patient. Make sure that they're not in pain. Make sure they're not in any distress. Make sure that they're not trying to reach over and get a glass of water that's too far out of reach, or trying to get their glasses that are too far out of reach. Next, scan the environment and your equipment. So make sure, is there bed low? Is there spills in the room that need to be picked up? Are there sharps? Is there anything on the floor that did not get put where it's supposed to be? And then if you have IVs running, always check, is it at the right rate? Is it going like it's supposed to? And those type of things. And then L is to look more closely, to really get closer to your patient, examine them a little bit better, go and touch their skin now, see if it's hot, see if it's cold, are they sweaty, anything like that. And then also look at the people that's in the room. Who are they? How are they related? How are they interacting? And those type of things. And we collect our data through our senses. Visually, we look at them, okay? We can get a lot of data based upon a patient's facial expressions. Are they guarding a certain area? Can they walk, or do they walk abnormal? And then also, how are they dressed? Is it appropriate for the season? And or are they dressed like they may not have been able to wash their clothes for a while? Those type of things. Smell. A fruity breath. If you smell fruity breath on anyone, that may indicate diabetic ketoacidosis, which we talked about a little bit earlier as high blood sugar. You can smell alcohol. You can smell just kind of some body odors as well. Hearing is another way that we collect our data. Basically, what do we hear? What is the patient saying? And then also, like when a patient's breathing, we can sometimes hear their crackles, so we can also hear that way. And then touch. Whenever you're doing your assessment, you can touch your skin to see if it's hot or cold. And then also we can just use touch as a reassurance for that patient. Sorry. Okay, so collecting your data. We're going to learn a lot more about this in chapter 22. We talk about physical assessment, but get these 4 ideas in your head right now. We collect our data through inspection. So that is your visual examination. Basically, what do you see? What are you seeing in the patient? Palpation is light touch progressing to deeper touch using pads of the fingers. Percussion is striking the body with the tip of your finger, and then auscultation is listening to lung sounds, or listening to any sounds, not just particularly lung sounds. So inspection, example could be right here. They are looking in their ear. Palpation is they're feeling for the apical pulse. Percussion, they're looking like they might be looking at the liver right here. And then auscultation, they are listening to bowel sounds in this picture. So preparing for your nursing health history interview. First, you need to know the purpose of the interview and how the data is going to be used in case the patient's going to ask. You need to make sure that you're prepared and that you're reading the client's chart beforehand. You're going to make sure that you have a time scheduled that you're not going to be interrupted and there's not going to be any distractions in that room. Make sure you have everything that you need, any forms, any equipment, vital signs, anything like that in the room with you. You want to look prepared, and if you don't look prepared, then you often look like the patient may think that you really don't know what you're doing. So we want to make sure that we always know what we're doing and appear to always know what we're doing. So when we're preparing the client, you always, every time you go into the room, you need to knock. Okay, that's just professional courtesy. That's always what you need to do. And then you need to introduce yourself, call the client by name, and tell the client what you're going to do and why. And then you need to assess them. Are they ready for an interview? If they're in pain, or if they're anxious, or if they're not wanting to discuss health issue, then your interview at that time is going to be no good, and you're not going to get the data that you need. So you just kind of need to back off, treat the anxiety, treat the discomfort, treat whatever is causing that, or it may just be waiting for family members to leave, and then you need to go in and conduct your interview. When you're interviewing a patient, we always need to be using active listening. And active listening, this is basically just being engaged in the conversation, just one-on-one with the patient, and you are not thinking about anything else. So you're not thinking about your to-do list, you are just focused on the patient. And some behaviors that promote active listening is that you're leaning towards the patient, you're facing the patient, you have an open, relaxed posture, no crossing the arms or legs, and then you're maintaining eye contact with that patient. Pay attention to their nonverbal communication, which is your body language. When you're doing the interview, avoid healthcare jargon. So, they may not know what hypertension is, so we need to say blood pressure, okay? Don't give advice or voice approval, disapproval. You'll learn this. That is not therapeutic. It's considered a non-therapeutic. And we want to use mostly open-ended questions and limit the amount of closed-ended questions. And open-ended questions, these are questions that a patient is unable to answer yes or no to, or like a 1 to 2 word response. Open-ended questions are questions that they kind of have to tell us a story so we can get more information about them on that. And these are examples of some open-ended and closed-ended questions that you need to look at. So we have all of our data and we need to validate our data, okay? Remember your objective and subjective data, you need to make sure they agree. So an example here is you have a blood pressure reading of 200/100, and the patient says that they have never had high blood pressure before. So what should you do? First, recheck that blood pressure, make sure it's accurate, and then go back into the chart and see if there's been any history. If there's not, that's a new finding and it definitely needs to be reported to the physician. And then also data that are outside of normal range. So if you have a temperature of 106 degrees orally, well, that's extremely way too high. There's a reason for that. So feel them. Do they feel hot? No, they don't feel hot. Okay, maybe they just drank some coffee. If that's the case, then we wouldn't have to wait and take it again later. So always validate your data. Documenting your data, if you, in healthcare, if you didn't document it, you didn't do it. So soon after your physical assessment, you need to make sure that you're documenting it. And then if a patient, if you're documenting patient's exact statements, then make sure that you use the quotation marks and never state your opinions in documentation, only document the facts. Okay, so that's it for Chapter 3 on assessment. Chapter 4, we're going to talk about diagnosis. So what is diagnosis? Diagnosis is to use critical thinking to identify patterns in data and draw a conclusion about the patient's health status by analyzing that data that you collected. So remember, we just talked about our assessment and all the data that we collected from our assessment. From that data that we collected from our assessment, we are now going to be able to formulate our nursing diagnosis. So there's a difference between medical diagnosis and nursing diagnosis. Medical diagnosis, the purpose is to identify a pathology. So it's something that describes a disease, illness, or injury. So some examples would be cancer, hepatitis C, fracture of the left hip, those type of things. Those are medical diagnoses. Nursing diagnoses are a statement of client health statuses that a nurse can identify, prevent, or treat independently from them. The following are going to be differences between medical and nursing diagnosis. So read through those. But basically all that says is just because in your nursing diagnosis book under the medical diagnosis of pneumonia, it doesn't mean that each patient is going to fit the nursing diagnosis of risk for deficient fluid volume. Okay, so you can't pinpoint everyone that comes in with pneumonia is going to have the same diagnosis, or breast cancer is going to have the same diagnosis. It's all going to be individualized to that patient. Nursing diagnosis describes health problems that can be addressed by independent nursing action. So it just identifies the patient's response to a health problem. If a patient just had a hip replacement, then a possible nursing diagnosis could be acute pain. Okay, that's an example of a nursing diagnosis. Nursing diagnosis is critical link of the assessment step. We kind of talked about that. And then based off your nursing assessment, you're going to create your nursing diagnosis, and then based off your nursing diagnosis, you're going to create your goals and your interventions. So everything builds upon each other, okay? We will talk about this more in class a little bit whenever we actually have lecture. But there's different components of a nursing diagnosis. How to write a nursing diagnosis. First, you have your diagnostic label. That would be like acute pain. And then you have the definition. That would be, what does acute pain mean? Your related to factors. These are cues, conditions, circumstances that could cause or contribute to the nursing diagnosis. One thing you have to remember here, your related to cannot be a medical diagnosis, okay? So acute pain related to a right hip fracture will not work. You cannot use that. So medical diagnosis can cannot be used as you're related to in a nursing diagnosis. And then you have your defining characteristics. This is where you're going to put your assessment data whenever you create your nursing diagnosis. So this is everything that you collected. So on acute pain, you would put patient statement. Patient states that pain is at a level of 8 out of 10. Patient has guarding of the right hip. Decrease activity, use of the right hip. Those type of things that you gathered from your assessment. Now there's different types of nursing diagnosis, but here we're only going to focus on 2. We need to get the actual and risk for nursing diagnosis down. The other ones, you may use when you've been a nurse for a while. The actual and risk are the 2 main nursing diagnoses that we're going to focus on. So an actual nursing diagnosis describes a human response to a health problem that is present. So it's actively occurring. And in the nursing diagnosis, there are 3 different components to it. You have your diagnostic label, your related factors, and your defining characteristics. So remember, we just talked about this. Your diagnostic label is your nursing diagnosis. Your related to factor is your etiologies that's occurred, and then your defining characteristics is going to be your evidence. So an example here is constipation related to decreased activity in fluids secondary to hip fracture. Now you can use, here secondary to is often a medical diagnosis. You cannot use it as you're related to, but you may use it as your secondary to. And then as evidenced by hard, small, formed stool every 4 days. Okay, so that's an actual nursing diagnosis that is occurring. A risk for nursing diagnosis describes something that could happen or they are at risk for it occurring. And these you don't have your as evidenced by. You just have your diagnostic label and then your risk factors or related factors. So an example here is risk for activity intolerance related to prolonged bed rest secondary to high-risk pregnancy. Okay? And here's an example here. Look over that chart there. Prioritizing your problems. Based off of Maslow's right here. Okay? This is going to be an important part in nursing. When it talks about prioritizing. Many of your nursing questions and NCLEX questions are going to focus on prioritizing, which means, who should you see first? What should you do first? And etc. like that. On Maslow, so the bottom level here is your basic needs. Your airway, breathing, circulation, everything that you must have to survive. Food, water, those type of things. After you've met all your basic needs, then you can move up to safety. And here, safety is, do you feel safe at home? Or do you feel safe at work? Or do you go into work every day feeling like you might be able to lose your job? Okay? So think about an abusive relationship. At home, they may have all their basic needs. But if a person that's in an abusive relationship, they're probably not meeting this need of safety. And the third one is going to be love and belonging, self-esteem, and self-actualization. On this top one, this is, you're not here very long. It's kind of like those high times in your life, like after you pass your first nursing exam or when you get your license for an RN, those type of things, you're going to be up here. So based off of Maslow's hierarchy of needs, which of these do you think would have the highest priority? Impaired gas exchange, fatigue, or dysfunctional breathing? So it'd be impaired gas exchange because that's a basic need. Fatigue and dysfunctional breathing are not a basic need. What if impaired gas exchange was turned into a risk for us, like risk for aspiration? So let's say you have risk for aspiration, fatigue, and dysfunctional breathing. The answer would still be risk for aspiration for that. Establishing priorities. Another word that you're going to hear throughout nursing as well is your priorities. A high priority is a choice that comes first over other possible problems. So it's based upon urgency or importance. And they can be those that are life-threatening, something that requires immediate attention, it requires immediate action, or it's something that's very important to that patient. So something that needs immediate attention is preparing a person that's getting ready to go down for a test. Something that's very important to the patient could be their pain level, or something that they need to say to someone before the surgery begins. Something that requires immediate actions could be someone that has impaired gas exchange, so they're not able to breathe correctly. Someone that's hemorrhaging, someone that is at risk for a self-directed violence, okay? So those are all high priority. Medium priorities are problems that could result in unhealthy consequences but are not likely to threaten the life. So examples of those would be fatigue, dysfunctional breathing, stress, incontinence. Low priority, they involve minor problems that usually can be resolved easily with minimal interventions. So pain after a minor surgery. Okay, that's usually low priority. If they had a mole removed or something, yeah, they're going to be in pain. We need to treat that. But it's not going to be as important as someone that's out in the other room that's possibly hemorrhaging. So, how are nursing diagnoses related to outcomes and interventions? Your nursing diagnosis suggests the goal, which we'll talk about next. And your etiology, or your related to, secondary to as evidence, those are going to suggest your nursing interventions that we will talk about here in a little bit too. So that's it for chapter 3 and 4.